Hi, thanks for joining us. Today, I'm Dr. Kristen Wigby. I'm a clinical geneticist at the University of California, San Diego and Rady Children's Hospital. And today I'm going to be providing a review of Trisomy X. I have no disclosures that are relevant to today's presentation. Our learning objectives are to review the background on Trisomy X, including medical and developmental and psychological features. And secondly, we'll review the genetic cause and proposed mechanisms that are associated with these features and variability. So for introduction, Trisomy X is a sex chromosome variation that's defined by the presence of an additional X chromosome in a female. It has multiple names in the medical literature, including 47XXX, triple X syndrome, trisomy X, or triplo X. It occurs in 1 in 1,000 live female births, but despite that fairly common incidence, only approximately 10% are actually clinically identified. These numbers are likely changing with advances in prenatal screening and increased genetic testing overall. And trisomy X is characterized by variable medical, developmental, and psychological features. Before we dive into these specific features, I'd like to take a moment to talk a little bit about the variability of features in trisomy X. So because the features that we will describe are variable, it can make it really difficult to predict outcome. And this can be especially challenging for families who are facing a prenatal diagnosis and trying to navigate their next steps. It is also important to keep in mind that for every female with trisomy X, there are other genetic and environmental factors that likely contribute to the presence of any one feature, as well as the severity of that feature for that individual. And so when we talk again about the medical features and the developmental and psychological features, really want to focus on these as health risks. That doesn't mean that they're going to happen, but these are health risks that we know are associated with trisomy X, and that by having an increased awareness, that can facilitate an early diagnosis and treatment. The second thing that's very important before we dive into what we know about trisomy X is considering what are our sources of information. So traditionally, a lot of the information was based on case reports in the medical literature and some cohort studies that were derived of individuals who were identified through clinical testing and then elected to participate in research. And that can create some challenges in terms of bias and may emphasize more severe features as opposed to the natural variability. And so we also balance that with important information that comes from prospective studies that have identified females with trisomy X from broader populations. This includes studies that were of newborn screening, where newborn infants received a chromosome study that were conducted in the 1970s and 80s, as well as new learnings from long-term follow-up of infants who were prenatally diagnosed, which is coming out of the Extraordinary Baby Study. And finally, other unselected populations, such as the UK Biobank. So in terms of the features of trisomy X, again, these vary from female to female and can include some subtle physical features, differences in motor tone and coordination, structural differences in the heart and kidneys, an increased risk for seizures and autoimmune disorders, as well as puberty and fertility considerations, as well as other medical problems as well. And then in terms of the development and psychological features, there are a few different things to consider, including impacts on cognitive and intellectual functioning, psychiatric concerns, and functional skills in terms of those adaptive and independent daily living skills. When we think about the features, they also are likely going to vary by the age of the child and the timing of identification, and whether that took place in a prenatal setting versus postnatal or after birth. In general, prenatal may be either as part of routine prenatal screening or prenatal screening associated with an advanced maternal age, or sometimes testing that's done as part of an ultrasound finding, such as identifying a congenital heart difference or a congenital renal difference in the structure of the kidneys. After birth, children may be identified either as infants or in childhood for various health or developmental concerns, or sometimes women may be identified as adults, sometimes through workup for other concerns such as infertility. In terms of the physical features that are described in females with trisomy X, there have been a couple of observations. So the first is that females tend to have a slightly taller stature expected for their family, with many having a height greater than the 75th percentile for their age. The median height is estimated to be between 5'7" to 5'9", with females tending to have relatively long legs for their body proportions. Subtle physical features can be identified in over 40% of females with trisomy X, and these include epicanthal folds, which are small skin coverings over the inner corners of the eye, hypertelorism or widely spaced eyes, fifth finger clinodactyly, which refers to a curved pinky finger, pes planus or flat feet, and hypotonia, otherwise referred to as low muscle tone. So low muscle tone or hypotonia and difficulties with coordination have been described in some females with trisomy X. And these are typically evaluated and treated in the standard fashion as you would for concerns for low muscle tone in any other child. And that may include physical therapy and occupational therapy evaluations and other treatment strategies. Some children benefit from orthotics for helping treat their flat feet, or in the school age, use of adaptive technology or keyboarding if handwriting and fine motor control is difficult. Therapeutic horseback riding also can be very helpful for building core muscle strength and tone. In terms of kidney abnormalities, these have typically been described in the medical literature in several different reports and affect the structure of the kidney and vary in the types. Some type may be identified as having the absence of one kidney, or a kidney that has many cysts and the structure is not quite formed correctly, to those that may have increased fluid on the kidneys or reflux of backflow of fluid from the bladder up the ureters in the kidney. And depending on what difference is found, there may or may not be functional impacts. And so the recommendation is that a renal ultrasound should be performed for all new diagnoses or by 6 months after birth in the setting of a prenatal diagnosis. In terms of cardiac abnormalities, the medical literature also indicates that there is an increased risk of congenital heart disease with trisomy X. Data from a prior cohort study of clinically identified females identified that 9% of females in this study had a congenital heart difference. And these were typically what we describe as septal defects, which is a difference in the tissue that separates the two chambers of a heart, either the top two chambers or the bottom two chambers, where there's a little hole or an abnormal connection. And so that may be referred to as a ventricular septal defect or an atrial septal defect. In this particular cohort, none of these required surgical correction and all closed spontaneously. And so the recommendation is to consider cardiology consultation or an echocardiogram for all new diagnoses or after birth in the setting of a prenatal diagnosis. Seizures have also been reported in increased incidence in females with trisomy X, and the most common seizure type that has been described are complex partial seizures. In our prior cohort study, again, these were clinically identified females, 16% reported a history of one or more non-febrile seizures. Often these started sometime in childhood, between the ages of 5 to 9 years, and had good response to medication treatment as reported by the families and medical records. There were no associated structural brain differences that were identified on imaging in these females, but it was noted on other measures that it could be associated with both lower cognitive scores as well as a female who may have been diagnosed after birth, such that seizures may have been part of the reason that prompted the medical workup that identified trisomy X. More recently, a case series from Italy was published, which also, again, reported an increased prevalence of focal seizures and as well verified a good response to AEDs or anti-seizure medications. So the recommendations include to consider a neurology consultation or EEG if there are symptoms and signs that are concerning for seizures, and appropriate treatment with anti-seizure or anticonvulsive medications as needed. In terms of puberty and fertility, there have been lots of questions related to what to expect and whether puberty is going to happen earlier, is it going to be normal or delayed? And this is an area of active research currently. There's been a few studies that have looked and identified some differences in the hormonal functioning of females with trisomy X. That have suggested that there's earlier activation of our pituitary axis, even without kind of the physical signs of puberty, and alterations in the levels of specific hormones related in the blood that impact the differences in ovarian volume. And more recently, Davis and colleagues reported lower levels of a hormone in the blood called AMH, or anti-Müllerian hormone, compared to females who were of the same age without trisomy X. And that suggested the possibility of reduced ovarian reserve. We also know that there's been many reports in the medical literature and from cohort studies of puberty occurring on time and progressing naturally with no clear differences in fertility. Another difference that has been mentioned, however, is that in a subset of females who have been studied and identified because there were concerns for premature ovarian failure, which again is the loss of ovarian function that happens before the age of 40. And interestingly, when just those females with concerns for premature ovarian failure have been studied, trisomy X has been identified in a minority of these females, about 1 to 4%. And so that tells us that there certainly could be some true differences there, but there's much more work to be done in this arena. In terms of the developmental and psychological features, this table summarizes a broad overview from many different sex chromosome aneuploidy or sex chromosome variation conditions. We can see that many of these are held in common and span different ranges of the developmental profile, including cognitive, language, motor and social skills, as well as more subtle differences such as executive functioning, processing speed, attention, and sensory processing differences, as well as social difficulties. And these all can interplay and impact the adaptive functioning or ability for females with trisomy X to function in the real world and in everyday life. Social and emotional difficulties have also been reported, which may include both anxiety and depression, and less frequently other mood disorders or psychotic features have been reported on occasion. And again, this is where we really want to turn attention to how in any one particular study were the females identified in that population, such that if the reports were coming from a study that focused on individuals with psychiatric disease rather than an unselected group of females, there may be differing reports in terms of what the association is with trisomy X. In terms of cognitive and learning function, studies have where females with trisomy X have been compared to their siblings have shown that overall full scale or FSIQ scores are typically within the normal range, but females with trisomy X may test about 10 to 20 points lower than their sibling matched controls. And that's what's demonstrated on the figure here in this slide. But furthermore, despite for the majority of females with trisomy X having a normal NIQ within the range of normal, there are higher than would be expected rates of learning disabilities. And so this is something for families certainly to be aware of. And some studies have certainly reported a higher frequency of need for special education supports in school, which may vary from testing accommodations to pull-out supports for specific areas. Cohort studies, again, have suggested also that this is important information for females who are prenatally diagnosed, that they have still been observed to have higher rates of learning disabilities and ADHD as well. In terms of thinking about treatment recommendations for developmental concerns, it is recommended to engage in multidisciplinary evaluations at key developmental and academic transition points. And here we just list in the numbers 1, 2, 3, and 4 specialists that are commonly involved in helping to evaluate holistically the functioning and development of a female with trisomy X. And at the top of the slide, you can see some of those key time points in which to consider those evaluations. Trisomy X is typically diagnosed on a standard diagnostic test that's referred to as a karyotype or chromosome analysis, which refers to essentially generating a picture of the chromosomes. Encircled in red is the presence of 3 X chromosomes, so 3 for tri, and so that's what we're referring to in trisomy X. This can be done in a prenatal setting when an amniocentesis has been performed and the fetal cells have been cultured, or from a peripheral blood sample that's obtained after birth. There are other tests that sometimes are used and can detect trisomy X, and that includes tests such as a chromosomal microarray, which is a more detailed picture of the chromosomes, which can also detect gains or losses of genetic information that are smaller than the human eye can detect, to studies that are very broad, such as whole genome sequencing, which also has the potential to detect trisomy X. Prenatal genetic screening tests, again, can also identify trisomy X. So for example, non-invasive prenatal screening, which is often referred to NIPS or NIPT, non-invasive prenatal testing. And it's important here to think about that these are screening tests that are indicating a higher or low risk for these particular conditions that are being looked for. And so the thing to keep in mind is that it's important to perform a confirmatory test either during the pregnancy or after birth if a prenatal screening test indicates a higher risk for trisomy X. And if confirmatory testing in the baby or fetus is negative, then it's also important to keep in mind that the mother should also be evaluated, as females with trisomy X have been identified as part of such a workup. Trisomy X can occur as a mosaic condition. Mosaicism is like thinking of the Greek tile mosaics that are essentially, you can have 2 genetically distinct cell populations within the same individual. And the picture here with the blue and white little diamonds is just kind of illustrating that this is a girl who's actually mosaic for a different sex chromosome variation called Turner syndrome. And so this can happen when a difference happens during the early cell divisions in a fetus, such that 2 genetically distinct populations arise and can lead to a mosaic trisomy X. And it's important that further medical evaluation and genetic counseling might be indicated in these conditions, particularly depending on the amount or how much mosaicism is present, as well as if one of those mosaic lines actually involves the loss of an X chromosome, such as Turner, which would be a mosaic form of Turner syndrome. So sex chromosome trisomies typically happen due to what we call a non-disjunction event. So in the population of making eggs or making sperm, you have to divide up all your chromosomes, copy the material, and then separate it into successive sequences to lead to each egg or each sperm having one copy of each of the chromosomes. And where things don't separate appropriately is often referred to as a non-disjunction event. What we understand from studies of what we call the parent of origin is that for trisomy X, most of these seem to happen in the egg and during the time point we call meiosis 1, although these events can also happen in meiosis 2. And the vast majority, but not all, typically happen in the egg rather than in the sperm. So when we think about why do the features that we've talked about with trisomy X happen, an important hypothesis for why they think this is happening is that you have extra genetic information from the X chromosome. And although all females randomly inactivate or turn off one of their X chromosomes so that you balance out the genetic material between a female and a male for the X chromosome, there's about 15, it's a little bit variable, but 5 to 15% of genes on the X chromosome don't turn off. And we call those as escaping X inactivation. And we think these are probably overexpressed in females with trisomy X. So one example is there's a gene that's related to what we call linear height, and it's called the SHOX gene. And we know that this gene escapes X inactivation and is overexpressed. And we think that, and this has been shown to be related or associated with the tall stature observed in trisomy X. There are many genes on the X chromosome that are involved in neurodevelopment, and so it's very likely that may be playing a role too. There are other factors that have been proposed that may also be important contributors to the variability of features in trisomy X. And this might include other rare variants in the quality of the genes, either on the X chromosome or genes on other chromosomes, other familial risk factors that might not be captured on current clinical testing, skewing of the X inactivation so that one X chromosome tends to be turned off more than another. And if there's changes again in the gene within the DNA sequence of a gene on the X chromosome, and it tends to be left on because of skewed X inactivation, that could contribute to differences. And finally, the role of environmental factors, which can also play a big role. So to summarize, although trisomy X is relatively common in 1 in 1,000 live-born females, the rates of clinical identification remain low. Increasing prenatal identification provides us the opportunity for increased knowledge, better monitoring, and early intervention for these females. And we're going to learn a lot more over time. There are variable features and health risks that are associated with trisomy X, as we discussed, and there's a lot more study that's needed to understand those factors associated with variability, though likely other genetic and environmental factors play a role. And so I'd like to thank you for your attention during this presentation, and we will be happy to take questions and open it up for discussion.